Well, greetings everyone, and welcome to the EKG case for the week of February 12th, 2013. This is a day late. I'm just getting over laryngitis, and actually I just got back from the National AAEM conference in Las Vegas, and they say what happens in Vegas stays in Vegas, but apparently I brought back laryngitis. And I wish I could have a great story for how I got this. I actually got it from my son just before I went to the conference. But anyway, speaking of great conferences, I just wanted to put a plug in once again before we get started for the Resuscitation Conference, May 1st through May 5th. It'll be back in Vegas, and hopefully I'll have my voice back by then. You can check out the website, www.resus2013.com. A fantastic conference. Okay, quick case before I lose my voice. And this was sent in by Dr. Hassan Al-Matik. And he has sent some really nice EKGs over the past year or so. And this was one that I thought was very timely because it was something I talked about during, or at least was on the docket for one of the lectures that I gave. And anyway, we'll get to the diagnosis in a second. It may be popping out at you, actually, but this is a 40-year-old man with mild dyspnea on exertion and some pleuritic chest pain who presented I think it was to a doctor's office. So Dr. Hassan did not actually see this patient. He just shared the EKG with us. I'm sure if he had seen the patient, he would have nailed the diagnosis in 2 seconds flat. Anyway, this 40-year-old guy had good health. He had no risk factors for anything, which for all of you practicing emergency medicine, you know that's not a good sign. When somebody's living a good life and they have no risk factors for anything, it's always predictor of something bad that's going to happen. But anyway, this guy's got a normal vital signs, normal respiratory rate, heart rate, blood pressure, no fevers, normal pulse ox, normal exam, normal everything. He gets a chest x-ray, which is pretty much normal. Well, I shouldn't say pretty much. It was normal chest x-ray, and 12-lead EKG was obtained because of the chest pain, even though it was pleuritic. And it was a pretty unremarkable EKG. The heart rate is in the 80s. There's really no ST elevation or depression, maybe just a tad bit of J-point elevation, which I don't think any of us would make anything of. This is just at most early repolarization. I'd probably just call this a flat-out normal 12-lead EKG. All right, so fair enough. Let's move forward. The patient, for whatever reason, got discharged with the diagnosis of pneumonia. Maybe that was a relatively convenient diagnosis, but Dr. Hassan also pointed out that there was some question about that diagnosis. There was no fever, cough, anything else like that. But he was discharged on some antibiotics and probably given some pretty good discharge instructions saying, come back right away if you do feel any worse. Well, he did start feeling worse. He got worsening shortness of breath, and his pulse ox when he came back was down to 88%. He had some increased shortness of breath. And those discharge instructions are really, really important. Whenever you have any uncertainty about the diagnosis, you give people good discharge instructions. Tell them to come back at the drop of a hat if they have any concerns for this type of scenario. This patient did come back with the increased shortness of breath, and now the EKG is repeated, and you can see that he has definitely developed some new findings. He's got T-wave inversions in the inferior leads, at least 2 out of the 3 inferior leads. He's also got T-wave inversions in V1, V2, and in V3, and in fact out to V4 and maybe V5 as well. So he's got inferior and anterior, at least anteroseptal T-wave inversions. And for anyone out there who's been listening to this video cast for at least a number of months, you know that when you've got T-wave inversions in the inferior and anteroseptal leads, even without this history, you've got to consider the diagnosis of pulmonary embolism. And this patient then went for a chest CT angiogram, and he was found to have very large bilateral PEs. And looking at the 12-lead EKG, it should be no surprise at all. Now, this is an important finding to be aware of. It's not a new finding. It's actually been described by Henry Marriott, who's one of my EKG heroes who passed away a number of years ago, but he's written some really great stuff on electrocardiography over the past handful of decades. One of the things he started talking about decades ago was that when you have T-wave inversions in the inferior and anteroseptal leads together, that is a highly specific finding for pulmonary hypertension. And if it's a new finding, in other words, you have an old EKG, in this case 1 week ago or a few days ago, an old EKG which does not show those T-wave inversions. In other words, if you have new T-wave inversions in the inferior and anterior septal leads, what is it in emergency medicine that produces new pulmonary hypertension? Well, new pulmonary hypertension equals large PE in emergency medicine. So from our standpoint, when we see new T-wave inversions in the inferior and anterior septal leads, you've got to think PE, number 1. Number 2, PE. Number 3, maybe number 3, you think PE. Number 4, pulmonary embolism. And number 5, pulmonary embolus. All right, so hopefully you get the point. PE, PE, PE. And this has been studied. It's found this combination of T-wave inversions in the inferior and anterior septal leads has been found to be enormously predictive of PE. And the problem is that a lot of people look at these T-wave inversions and they say, this must be acute inferior and anterior septal ischemia. Let's give them aspirin and maybe get a stress test or something else like that. And invariably, these patients end up ruling out for ACS. And if you're smart, you'll work them up for PE and then you'll make the diagnosis. We recently completed a study at our university which corroborated what multiple other authors have found. We found, I think, about a 75% predictive value when people have T-wave inversions, inferior and anterior septal leads. At least 75% of the time, it turned out to be a PE, and only the minority turned out to be ACS. So, simple take-home points. Here, PEs, of course, PEs can be associated with normal EKGs and normal heart rates, just like this patient presented with a few days ago. But large PEs very, very, one more time, very commonly produce T-wave inversions. And that's not commonly taught. Most people think about tachycardia. And in reality, large PEs are probably more likely to produce T-wave inversions. So when you see T-wave inversions, don't just have tunnel vision and think ischemia, ischemia, ischemia. Think about pulmonary hypertension. In other words, in emergency medicine, think about large PE. New T-wave inversions equals large PE, especially when they are simultaneously occurring in the inferior and anterior septal leads. There's one cardiology study from the American Journal of Cardiology which actually said that when you've got simultaneous T-wave inversions in the inferior and anterior septal leads, it was about 98% specific for pulmonary embolism. That's incredible. In our study, not quite that much, but 75% definitely. So when we see new T-wave inversions in the inferior and anterior septal leads, that is a PE until proven otherwise. Now, we've talked about this on the videocast before, twice before. The last time was June 24th. So if you want to go to the website, scroll back to the June 24th, 2012 case. You'll see a few other examples of this large PE producing T-wave inversions in the inferior and anterior septal leads. And again, when you see new T-wave inversions, one of the things that you've got to think about, one of the things you've absolutely got to think about is pulmonary embolus. And if they're occurring simultaneously in the inferior and anterior septal leads, then that is enormously specific for pulmonary embolism. So I hope this case is helpful. My thanks to Dr. Hassan for sending this excellent case. And I hope you all pick up those PEs that present with this. This is something that you will see. It's not a zebra diagnosis. Be on the lookout for this in those large PE cases. All right, hope to be back with my real voice, my normal Sean Connery voice, next week. And until then, stay healthy.